We're gonna get started. Sorry for the delay.
All right, guys, happy Thanksgiving week. I'm supposed to do the welcome. I don't know what that consists of, so I want to thank you guys who are here in person, everyone that logged online. We have an agenda here. Just FYI, me and Quincy will be stepping out a little. Well, I thought we had 20 minutes here, but since we got started 10 minutes later, we have a budget meeting with the Ways and Means Committee, so we'll have to step out around 2:25. I wanted to thank all of the DSN providers who participated in the meet and greet. I've gotten some emails from you guys that were really positive. I'm sorry I have a really bad habit of starting to respond to an email and someone distracts me, and then a week later I see it in my draft box. Yeah, I got a 2-year-old, and so my world's kind of upside down. So everybody, I got your emails. I'm going through my draft box now to make sure I didn't miss responding to anybody. We will do meet and greet with the private providers sometime next year. Is our hope. We've got some other things starting in the beginning of next year, but we're gonna make every effort to start those around February of next year. Who am I pitching it to? Margaret?
Yes.
Margaret,
Margaret's
DHDD updates. Thank you, Margaret.
Good afternoon. I don't know where to look. I'll try to split the difference. Okay, just a couple of updates from the HHS perspective. So I'll tackle rates first. Within our budget request, we had a specific call out within our decision package to support increases for residential habilitation. This does include language around both ResHab and day activity. The intent is to assist with additional rate actions, specifically in support of getting direct service workers' hourly wages up to a certain point that is more competitive. So just be aware. I don't think those have been shared publicly yet. So at the time that is appropriate, when they get through this phase of the budget process and have been posted publicly, please support our budget request. That would be the ask from us. So just know that is in specifically to assist with direct care workers' wages within our fiscal 25. So I will say also in addition to that, Heather, I sent some links to you. I'd be glad to share it more broadly if needed. There is a proposed rule out by CMS. It is just in the NPRM or proposed rule status. They have requested public comment on it, but it has to do with access and support for home and community-based services. There is also a separate managed care proposed rule kind of packaged with it, but there are some good handouts and some good fact sheets on that proposed rule. I think one of the items that would be pertinent for the provider network has to do with proposed requirements that would identify a specific percentage of rates that would have to pass through to direct care workers. So for instance, in the proposed rule, it would require if the Medicaid agency pays a provider agency a rate for service, then there would be a specific percentage that would have to pass through to the direct care worker. And I think that would have the effect of somewhat capping or limiting the amount of the rate that can go to administrative and overhead and the amount that would need to pass through to the workers in terms of their hourly wage.
Is that the one you sent me?
It is.
Okay, I'll send that out to everybody.
Okay, great.
Okay.
I think I sent 3 links. There's the actual rule itself, which is a bit tough to get through. There is a fact sheet that gives more of a brief synopsis of what the rule is proposing to do. So we just want to make folks aware that is out there. It is not in a final state. It is proposed only, but would have pretty big impact on the network, on ensuring that rates are passed through to direct care workers and adequacy of the provider network. Mm-hmm. So that kind of goes hand in hand. Cost of living and the retro rate adjustments to 7/1. We do have those rates finalized. I am in the process of doing a final review. We'll be sharing that with with DDSN. They will have to do their thing in terms of updates, but know that those are coming shortly. We've got the rates. We just have to go through the process of getting them loaded. And then on DDSN side, getting all the required updates. We will do a similar process as we did last year to address adjustments for the time period 7/1 until the effective date that the new rates are in the requisite systems.
Yeah, as soon as we get the rates, I'll get with Sarah to determine how long it'll take to update them in their system. And like Margaret said, we'll do similarly what we did last year, where whatever date they're changing there, it will be a future date. There'll be a reissuing of all the auths, right? It'll require migration. And then once we have that, HHS will go in and do a provider level adjustment for anything that was billed from 7/1 until the effective date in TheraP. Typically, TheraP takes 60 to 90 days to do anything. So once we have it, I would expect it'll be at least 60 days before the auths are updated.
There is also, in terms of technology first, I believe that was on the list. Y'all keep me honest if I'm jumping the gun on our agenda. But there should be, for a small group to get together and talk about next steps and how we see that coming together. There's a doodle poll or whatever type of poll going around to try to land on a date for us, small group of providers and DDSN, to get back to the table and kind of talk through with the expert that's been identified how we want to proceed, ideas, things of that nature to keep that moving forward. So that date should be forthcoming.
Can we ask questions? Okay. So as far as, I know this kind of came up in a meeting that you were at Friday that I could not be in, but as far as ICFs, we were talking about the rates and we're working on the rates for residential have and it being in the budget and the increase with the DSP rate. So when it comes to a non-waiver service, for example, ICFs, Medicaid billing, how is there anything being proposed to help us be able to reflect that pay increase as well for our direct support staff in the ICF settings?
So we did not include a separate item for ICF within the budget request. We would have to take a look in conjunction with our efforts to shift to direct billing, which contemplates a review of rates, facility-based rates versus a statewide rate for community ICFs. We would need to look at it in conjunction with that.
Okay.
So when we completed our FTE reports, which is helping to build this rate structure, we included our ICF employees. We didn't carve them out saying these are separate from that. So I wonder how much of an impact that actually has on the rate by including those FTEs.
So when we do cost reports,
Yep.
we submit an institutional cost report for all our ICFs or regional centers as well as community ICFs. And Jeff usually builds in a prospective increase for workers. He has traditionally the last couple of times, so I'm assuming that's going to be the same way. It's going to be a cost report.
So let me say this, and I could be wrong, but I think there's kind of two things going on at one time. There's the COLA and that increase, right? And I think that increase is applicable to all FTEs, hence the FTE report, right? This additional rate increase that they're asking for is waiver specific.
Yes.
So I don't think they're intertwined, if that makes any sense.
It does. I'm with you.
I just know so many of us are trying to, because it's 8 beds and a lot of us are already self-funding, increases and trying to recruit staff because it is harder at times to get someone to work in an 8-bed facility. So we are, I know for us, we're paying a higher rate for our 8 beds and for our ICFs. And so for the new rates, which we're so excited about and appreciative and going to support the, the human service budget, but I know that then we're going to have an issue here because, we'll have to do something for our staff that work in those 8 beds and, it can just get tricky. So anything we can do or any information you guys need from a DHHS perspective from the association or anything, please let us know, because,
Okay.
you know, I'll be, you know, like I said, you know, I volunteered for us to be the pilot with direct billing as well. So we can, you know, anything we can do to assist with that.
Absolutely.
Yeah.
And we know we have to look at the system as a whole because it has you do something here, it has an impact here. So
Yeah.
I recognize we have to look at, you know, all of those reciprocal impacts.
One last question on the rates. Would you anticipate, and I know we don't know for sure, but would you anticipate those new rates being published, the COLA adjustments being published at some point in December?
I'm doing the holiday math, but yes, they will be announced by a Medicaid bulletin
Yeah.
that list all of those. That usually takes warp speed a couple of weeks to get through all of our internal clearance and review. So as soon as we can get that routed through, we will do so.
And then Laura, you said 60 to 90 days after that would be?
I said they're typically take
Takes
60
that
or
long.
90 days. And you know, what will happen is, once I get those rates, I will take them to TheraP and say, we need to come up with a date in the future that you think you can do this migration, right? Because if they don't do a migration, then somebody's got to go in and manually end all the auths and reissue all the auths, and that's for every service, so it's kind of super messy. But we will do, I will work with them to come up with a date. I don't remember last time what the time frame was from when I got the rates to when we did the adjustment. I think it was about 60
We
days.
got the adjustment in January, and I think it was published in, we got the Medicaid bulletin, maybe November.
That sounds right.
So maybe we'll get it in January, right? I mean, just depends.
But that was getting the Medicaid bulletin or the rates published sooner than we are this year, so I don't know that.
It might be February.
Yeah, I think we're tracking a little bit.
Either way, you know, it will be, we will come up with a date. We will let HHS know what the date is so that they can begin work on getting your adjustments from this date to this date. The trick is going to be getting all your billings in before they do the adjustment, so that you get it all in one lump sum. Because when stuff starts trickling in, it's difficult.
Y'all see, what happened to last year's? Do we ever get that people that might have went back and billed after that date? I don't think it was still.
How many provider level adjustments did y'all do? Did y'all do it twice or once?
I do not recall.
And
I know there is a certain run that we're going to need to do in conjunction to make sure
Right.
we've caught anything that
Right.
wasn't adjudicated in the
That was
first
kind of our
adjustment.
thought, like, we might do one last run that goes back to the first adjustment.
I guess to be precise, what happened last year, we started receiving payment with the new rate a couple of months before the adjusting payment or retro payment came. So there was a couple of different actions that happened.
Which makes sense, because you want all your billings to be in before you do the adjustment, right? So. We'll get it done as quickly as we can, and we'll keep you updated, right? So as soon as I have a tentative date from Sarah, I'll let you know what it is.
Also, there was a question that I think I need a little more additional information or clarification related to OSS, optional state supplement.
Don't know who asked it, because we didn't bring it on our computer.
If we can identify who asked it, I'm happy to follow up.
I'm happy to go check and see. It was somebody who signed up to be in person, so it was not one of y'all in the room.
Let me know.
But yeah, I'll let you know, Margaret. I can follow up with you.
Those are my updates.
All right, Harley, I think you're on next for quality management updates.
So Anne unfortunately could not be here today, and so I have some updates from her based on the questions received for the meeting today. Obviously, if this doesn't answer your questions, please reach out to her directly. Her email address is adalton@ddsn.sc.gov. And there are some links on this that Lori will be posting on the chat, so y'all can access those, but they're all on the quality management.
I'm gonna post them by section, right?
That's fine, yeah.
Okay.
So, one question came in about incident management report returns, and this is from Ann directly, so I'm just gonna basically read it verbatim, but the incident management report submitted to DDSN need to cover who, what, when, where, why, and how. The questions asked by DDSN incident management coordinators are the same questions a provider's own risk management team should be asking about incidents to understand what happened and what actions have been taken in response. This oversight is expected to grow as new regulations are finalized through the CMS access rule and the ACL's proposed standardized reporting requirements, which are both expected to be issued in spring of next year. There's a quality management bulletin from July 2023 that outlines reporting requirements, including the ED or their designee's role in reviewing reports for content and clarity prior to submission. In addition, there was a section with questions to ask prior to submitting reports to DDSN. A copy of that bulletin was posted on the Quality Management Division's webpage on the DDSN website. Within that webpage, there's also a link to a handout on the reporting process and includes questions mentioned in the bulletin, but additional questions specific to incident type. Follow-up and corrective actions are also covered. As a reminder, that incident management process is not just about telling what happened, but it also includes the remediation corrective actions the provider has to take to either mitigate the issue or prevent reoccurrence. Documentation must be available as evidence to those efforts. And so she provided links to that bulletin, and then of course to reporting information, as well as just general incident management information.
We included those links in the chat. For those of you who are here, we'll get those links sent out to the masses, so you have them.
And then there was an additional question or topic called the QM process. And just noted that all of those processes for the different service delivery types are located in individual sections on the DDSN website. And there are links for review documents, review preparation tools, and to know what information is or must be available on site for licensing reviews or uploaded for administrative compliance individual service reviews. So I know that y'all may have wanted to have a more thorough discussion, and I'm sorry that Anna's not here to facilitate that. But if you have any specific questions right now, I'd be happy to take them and follow up with her.
Harley, yeah, I think because this just came up for us, and we really try to work with the QM division at DDSN, and as you can imagine, and I'm sure that you've heard it different times, it can be very frustrating because we do feel like we do a thorough analysis and we're getting that feedback back, we're getting that information back, and we're trying to ask those questions, especially when it's a choking incident. But we recently had an issue where there was an individual at the day program, and it was a choking incident, and there was no past history of the choking incident with this individual, with the exception of when he was 8 years old, a brief situation on some Jell-O or something. But the father called me really upset because we were asking him a lot of the questions so we could follow up and do the follow-up with the CI situation. And he was just really upset with us because we were asking so many questions. And so I think that we need to have a discussion and maybe further dialogue. When it is an individual that lives at home in the community, they do receive a day service, but we can't dictate or mandate that families do certain things when it comes to the overall care of the individual. And that father has the ability to make that decision and that call of action if he felt like his son needed to have further medical attention. So I can understand, and I listened to him and I reaffirmed him, that we were going to submit the information that we had. But I do think that there is some, I understand when it's happening in the provider network, especially it's in residential, but when it's somebody that lives at home and it's something that occurs in the day center, I do think that there is some limitations on what a provider can follow up on and information that we can provide on the IMS system. And I want us to have that further dialogue and to look at that. And if Ann wants specifics, I'll be happy to talk to her, because this father was very upset when he called me and we had a discussion about it. So I just want to mention that, because I do feel like that's something that we might need to look at.
Absolutely, I'll make sure to share that with Ann, and maybe it's something that could be discussed with the provider focus group or in a different forum, but we'll continue to have those conversations, but I will share this directly with her. Anything else about quality management that you'd like me to share with you? Are there any questions on the chat?
All right, so I put both sets of links in the chat, and again, like I said, I'll send them out. Harley, you're on the next for communication updates.
So these are kind of just miscellaneous updates, but I just wanted to remind DSN boards to please don't forget to submit a nomination for the Silver Palmetto Award by the end of December. Again, it recognizes a city or municipality that has displayed exceptional service to individuals we support. Memo and reminders have gone out about that. And so if you have any additional questions, you can reach out to PJ Priya. His email address is Pacifico, PACIFICO.Perea, PEREA @DDSN.SC.gov. To tack on to what Margaret said about the Tech First initiative, we're working on a contract with the Human Service Provider Association related to this initiative. And so I have all the information I need, I think, to draft that and get that out for review. So look forward to meeting with y'all to kick off that project. In addition, a question came up about TheraApp module. And so I just wanted to give y'all a quick update about the EHR solicitation and request for proposals. So we've been working with MMO, the General Management Office, State Procurement, to go through the request for proposal or RFP process for a new EHR vendor. And so we've reviewed proposals and we'll be scheduling demos in the coming month or months, along with some of the subject matter experts that have been identified, not just within DDSN, but also the provider network. And really, until we know the direction of that solicitation, right, in the sense of what direction we're going to be going with regards to an EHR, I don't think it makes sense to implement any new modules in TheraApp. We want to continue the status quo, so to speak, with what we've got available to us. And of course, things like rate changes, we'll obviously work with them to update. But anything new, I think we're just going to put on hold until we know what direction that we're going. Is there anything else you want to add to that, Lori?
I don't think so. I think ISP billing, the struggle with ISP billing is there has to be a standardized ISP for residential in order to accomplish ISP billing, which is kind of a massive undertaking. And it's going to require the work of people here and y'all, because I don't know of anybody here that can do a standardized ISP for residential without some input. Because I know everybody's doing it a little bit differently. But, I think regardless, to Harley's point, we are currently in the process, or we're ending the process related to the EHR RFP proposals. And until we know for sure the direction we're heading in, it doesn't make sense to move anything new into that.
What's the timeline for it being chosen, the RFP?
I mean, I think that our current timeline is probably early next year,
Yeah.
right?
Early
So-
January, February. Then, if it may very well be TheraApp, right? If it is, then we can start thinking through the next modules. If it were a different vendor, then there would obviously have to be a period of transition and
Different kind of rollout, right? It
Yeah.
would look different versus, for a new vendor versus an existing vendor.
So is it already like the deadline for vendors to submit an RFP?
yeah, that's all.
everything. Yeah, the only thing left to do is demos.
And can we ask how many people submitted RFP?
No.
No, okay.
We can't
I
provide
thought I'd
any
ask.
details yet.
Yeah.
Well, we can ask, you just can't.
We do have, provider representation as subject matter experts that I don't know.
That have received the proposals and will be invited to the
Right, they
demos.
have the information.
Once we
but
get
they can't
those.
sue either,
Yeah.
because they've signed a bunch of stuff.
Oh, okay.
But
What about for, there is a ISP for employment, individual employment and SLP. So what about those two services?
sure, it's an all or nothing to turn on ISP billing.
I thought that residential would still stick with attendance.
So it's an all or nothing to turn on ISP billing with their. So yes, we have a standardized ISP, but they're not going to turn on ISP billing until it's all in ISP billing. It has to do with the way their system works, right? So there is some functionality that, for those of you, I don't know if you're familiar, like your agency uses them in another state, right? So our system is tied very tightly to the authorization. Won't let you bill, like we bill off the auth. In other states, it's a little more flexible in the provider world because their systems are not necessarily tied to the auth. In fact, you just receive an auth and then you do your own thing, right? So as long as our system is so tightly tied, we have to stay with a certain course. That's what the problem is, right? So they have functionality that would allow a provider to turn on ISP billing for certain things and turn it off for others. The issue is all of that stuff at this point is controlled here because it's all tied together from the plan to the auth to the ISP. So we've talked about whether or not we should go that route. The problem with that is you lose a lot of control when you do that. Basically, it allows providers to bill more than what's on the auth because they enter their service auth manually.
If you were doing it on the portal, you could do it that way.
Correct. That's correct.
So you limit.
I hear you.
Okay.
And like I said, it's been a consideration and it's just something that we haven't done yet. When we were talking about it, there were a lot of things that needed to be corrected in the system. So we kind of went there up and said, let's go backwards and look at everything that we have and try to get it where it needs to be. And then we can talk about ISP billing. And it just so happened that ran up on the solicitation for a new EHR. So it's kind of been put on the back burner at this point. I think we'll know early next year what direction we're going in. And then once we do that, we can start talking about the right way to do it.
I just have one more thing I thought of. I had given an update about piloting a level of need assessment within the provider network, specifically residential, right, to see if this tool can be utilized for what we would like it to be utilized for. And I just wanted y'all to know that solicitation's been posted. So I think I don't know the date of when we will get proposals and such, but early next year, we'll have more information about how we'll roll out that pilot project and what it'll look like for providers that would be participating. So I just wanted to mention that we have moved forward, at least somewhat.
On the way.
Yes.
Can you repeat that one more time? I'm sorry, I missed the piloting. What are you piloting? I missed.
A level of need assessment
Thank you.
to eventually get to tying dollars to individuals rather than settings, right? I think is the goal.
Do you know how many will be in the pilot?
I cannot remember what's in the pilot per that Edmetric, the vendor who developed the pilot. I can't remember exactly the total number.
But it's a very representative sample of people,
of all the
kinds of things.
residential settings, including ICF.
Right.
That's all for me.
Any questions for Harley? I don't see any in the chat.
And I will say I do have to pop out to go to.
Harley, I've got one.
That is terrifying. They are leaving y'all with me.
I know, man, I'm dropping like flies.
And
Listen.
Margaret has to leave too, like, in like 10 minutes. So it's gonna be like, y'all better not pounce on me, because that's not nice.
You left the best for last.
What's really bad is I was supposed to be off today,
Oh.
and then I said, you know what, I'm just gonna go in. I've been, ever since I got here, I told Harley, I should not have come in here.
That always works out. Hey, Harley, I've got a question for you. Go individualized living supports. Do you know how many providers, or has anybody started providing that service?
Independent living skills.
The provider application just went live last week.
Right.
And so that's the first time we're able to recruit providers or qualify providers.
So good.
If you just wanted to add it to your current services,
You gotta apply.
You have to apply.
You gotta apply for it.
The same process.
You don't have to apply for a service that you already deliver,
But
only
if you
new
want to do
services.
that, you have to.
Yeah.
And if you don't apply now, when would be the next window to be able to do
Rolling.
It's
that?
rolling.
So you can do it
Yeah.
anytime.
It's
Okay.
rolling, like we wrote into the policy, I think, that we only have to review them every quarter.
Right.
So that when we get down the road and, and applications are trickling in, that we might end up with a schedule. But for now, we need providers.
Yeah.
So
So
we're
you're
gonna
good
be churning as they go, right?
It's more of reserving the right to only do it
Correct.
quarterly, but we have no intention of
Yeah,
doing that
there's
right
not gonna be a
now.
window. You can apply at any point.
Okay.
And there's a whole section in the agenda specific to that process.
Yeah.
So if y'all have other questions,
Yeah.
Lori can answer those, especially for those on the call too, like virtual.
Is the rate for that, I assume, being bundled into these new rate announcements that are going to be going out? Or is it's not a carved out standalone rate? I mean, I know it's a standalone rate, but outside of the HCBS rates, right? Or is it like ICFs, it's going to get touched separately?
No, I think it's like personal care or nursing or something like that. It would get touched separately.
Okay.
Because it's open to, or respite, right? It's
Yeah.
kind of that, it's in that group of rates, I would think, right,
Okay.
Margaret?
So it would not, I guess to better state my question, it would not be appropriate to assume that just because some rates are getting touched, that the independent living skills rate is going to get touched.
In terms of the COLA or just rate review or?
Well, I guess COLA, I guess I already know the answer to my question. The other,
It hasn't
other,
been put into operation, but
Right.
we have developed the rate
Yes,
already.
the rates are out there on the rate.
It's on the fee schedule.
Yeah.
yeah, and I guess I was just wondering if and I think Laura, you've answered my question, is it going to be treated separately like respite and other rates, or is it going to be bundled into some of these rate reviews that we are always anxious for?
Again, I think we always have to look at the whole system and the array of services, because this is something new
Yeah.
that we haven't implemented, but are in the middle of implementing, just starting. And I think when you review the rate, it was built with certain assumptions. And I'll have to go back because it's been a minute, but it's a pretty substantive rate, because again, it's designed to be more of a one-to-one training type of service. But we are always open to feedback if we're seeing difficulty with sustaining it. at the
Well, I just
establishment.
know, and maybe the feedback would be more appropriate once we apply and start providing that service. But our initial, just candidly, talking dollars and cents here, initially, because Haskell and independent living skills is a big focus in our programs, our initial response is, oof, I don't know that rate entices us to get into that space. I don't know that we were looking at that being sustainable from our standpoint. So we've got to still decide, is it something that we're going to explore simply from a rate standpoint? But having said that, I concede we're not currently providing the service, so I can't tell you, no, it's not sufficient, and here's why. But just our initial pass at it was, I don't know, that might not be sustainable from a rate perspective and cost, but.
Do you have the same concerns? Similar concerns?
But I know it's easy to say, hey, that's not enough, give us more money. I understand that. We don't have data to show you that it's insufficient because we're not currently doing it. But that was just our response.
Again, happy to have further
Yeah.
conversation.
Yeah, sure.
As you see the requirements and.
Yep.
Yeah. Happy Thanksgiving.
Yeah, y'all have a great one.
I'm gonna take Quincy's item because he had to step out. I wasn't listening closely when you were talking, if you said much about EVV.
So what I can give by way of update is we have been working to finish the writing of the RFP for the new EVV system. It's in final review, so we've asked the work group and others to take a review, do a final pass, any feedback. Once it is finalized, then it will go through the state procurement process, but we're at final revision of that draft RFP.
Right, and I think the message is, you know, the EVV process, it kind of started over a bit with a new RFP. Just be on the lookout for any kind of information in the future as we look to, you know, roll it out. In the meanwhile, you guys might have heard that we are trying to get a new fiscal agent contract, right? So in the coming months, we're going to be working with the current fiscal agent vendor to transition to the new fiscal agent vendor until we get to EVV, right? So kind of bridging it. And those responsibilities of the new one will be processing payroll, withholding taxes, issuing new W-2s. For the self-directed programs, we will be sending out communications to the people who are receiving self-directed services, their workers, the case management providers and their executive directors, as well as the case management supervisors. So you guys will get notification well ahead of what's happening when it's happening. So the new vendor is going to likely attack it by some level of category or region. We can't sift all 3,000 people at one time. So it'll kind of be a tiered approach. But you will get stuff, we'll kind of tell you what's happening, when it's happening, and give instruction as we go. I hope y'all don't have any questions about that. That's not mine. All right, so policy updates. I think we had a question about the background check policy. We are still waiting on having a meeting with the Attorney General's office. If you remember, we sent them a request for a interpretation of what's in the law. They asked us for a meeting, so we're trying to schedule that meeting now. I'll keep you guys posted as we move forward with that, and let you know, kind of what's going on. There was a question about legally responsible adults being able to provide service. If you recall, there was a amendment that was done recently that changed the family members providing care policy. And the major change to that was it allows for legally responsible people to be paid for the service, right? So not parents of minor children, but let's say there's a legal guardian. There's kind of this line of financially responsible is where the line is drawn. What we've kind of instructed case managers is if you have somebody and there's a question about whether or not the legal guardianship would be allowable for them to be paid for care, to please send it to us. We'll consult with HHS and make a determination. All right. like I said, that information has gone out to case managers. There was some training I think HHS did a few months ago on it, and then we've kind of reiterated it. So if you run into any questions with that, just let us know. Provider qualifications update. We did finally get the application posted on the DDSN website. I've got a question out here about where it is, so I'm just going to tell you. You go to providers, qualified provider application, and there's a link. Basically, it says, thank you for your interest. Here's where you go to get it. There's a place where you send it by email to DDSN, and then we'll be in contact. We are updating. This won't really affect you guys right now because you're all Medicaid enrolled providers, but we will be updating the contract to indicate that the contract is not valid. No billing can occur under the contract until the person has the Medicaid provider ID that allows them to bill that service, right? So it's kind of just that little safety net there so that people understand that they can't provide the service until they've been all the way through the process, because they come to us, then they go and get a provider ID, and then they come back to us, and that's when they can receive authorization. Any questions about the provider qualifications application? People won't go on the list as a choice until they have a Medicaid provider ID as well.
No, I mean, I think the memo that came out, I mean, if we already enrolled, there's really not, unless we were going to do another service, though, there was no lot of action on our part, correct, with that, so.
You're going to do a new service, you apply. For everyone, there will be a reapplication or not a reapplication, I forget what we called it. It's like a review, basically, kind of a reapplication, re-review of some items that has to occur, I think, every 3 years. It will be a modified application process. So, you know, that should.
Not having to reproduce that binder full of information.
Well, if you
is
look
very-
at the
very
application,
helpful.
if you look at the application now, it's not a binder full of information, right? The new application is scaled down.
Well, I'm so grateful. Even if it wasn't a lot, it's nice not to have to go through that when your current provider.
Sure.
So thank you.
But I think even new providers, we try to scale it back so that we are actually reviewing what is important, right? Does the provider have the ability to do the service? And when we ask you for stuff, we're asking for attestations, not necessarily copies of stuff. Like, you know, before we would say, you have, instead of attesting to, you have to make us a copy of the stuff that's already out there that's ours, right? So that, we kind of took that piece out of it. So hopefully it will be much more user friendly, and we can get people through and on the provider list more quickly. So the other thing, and this question has come up a couple of times, I want to make sure that everybody clearly understands your current contracts indicate what services you can provide. They don't indicate where. They say you can do res hab, tier 1, tier 2, you can do waiver case management. It doesn't say you can do it in Aiken County, you can do it in Greenville County, you can do it. So if you want to expand your counties, all you got to do is let us know that you want to be added to the provider list for additional counties. So it doesn't require reapplication. You just, once you're approved to provide the service, you can adjust where you provide it. So just let us know if you want to be added. All right, the last thing on the agenda is the residential needs process, and somebody just wanted to discuss that. So I just wanted to kind of open the floor.
I'm so sorry.
I know you are. And to talk about the residential needs process, I've met with focus groups about this. We know that there is room for improvement in the residential needs process. But I just wanted to give you guys an opportunity to talk to me a little bit about your experiences and, anything that you would like to see us consider related to the residential needs process?
It was me. I'll start.
Okay.
Just frankly, it's too slow. It's costing me money.
Yeah.
Lots of money. Over time, it's going to be for all of us a lot more money. It's got to speed up.
So explain, like, give me,
If we vet people, which that's not the part of even starting the clock on. We're very interested in someone. We've got to work with a third-party case manager. I know that's all the land house we do. If they're off for a week, they're off for a week. They're in no rush. So we deal with that.
so the slowdown is at the case manager, not at the committee, or is the slow at the committee?
It's both. And my question really is if case managers have the responsibility to be a part of this process, why don't they have the authority? I'm not sure why there's even a need for the committee, unless there's a dispute. Like if the residential provider, the case manager, are all like, hey, this is in this person's best interest, why are we coming to that level with it?
Same reason every service is not approved by a case manager. When you start talking about conflict, right? If a case manager is deciding how much, how often, from who, what level, it would be very easy for a case manager to just be saying, okay, come to my agency, we'll give you whatever you want.
Luckily for you, they're not doing that. But
No, but I will tell
then
you,
why do you give people always thinking when I do in my shop is if you've got the responsibility, then you've got the authority. So if they don't have the authority, they shouldn't have the responsibility. It should be yours. So we should just work directly with you.
but the response, but we don't allow nursing providers to come directly to DDSN and say, Johnny needs 35 hours a week of care. We don't allow personal care providers to come and say, we need an increase in the number of units, right? I mean, what we did with residential needs is what has always been there for every other service.
Okay.
And so the issue is that prior to the switch to fee for service, all the case manager had to do was justify the need for residential. Somebody needs residential half. They didn't have to figure out at what level, how much, what's their, basically they just said they need residential. And then DDSN billed the same rate for everybody who got residential and then negotiated with its providers about how much we would pay you for Johnny or Sally or Susie. When the tiers were built and it became a discrete Medicaid service, there's got to be justification in the case management record, in the case management plan to say that that person needs that level of service. That's the issue. It's not just about we want to throw the case manager in it. It's got to be in the waiver file because it is a different, CTH2 Tier 2 is a different service than CTH2 Tier 3 in CMS's eyes.
Sure, but to us, there's a disconnect, to me.
No, I hear you.
To me, there's a disconnect, and what you forced me now to do with this new process is like, I can't give anyone a chance anymore unless I'm dead certain that they can go from CTH to SLP2. Because if they fail, for a reason that we believe is a failure, but it doesn't align with your definition, which I get can be different. I'm not saying you gotta have mine.
Right.
Then I'm stuck. I cannot move them back to where I feel like they're safe and that everybody around them feels as safe, except for somebody sitting down here in Columbia.
Yeah.
So it's getting vetoes. And that's an issue. The other side of the coin is, so we've got the young people with autism, and I know you're very aware of those. We've also got to pay attention to the statistics of we've got an aging pop.
Yeah.
They're aging. Either we're going to, and you and I have had a discussion on this, but I'm just bringing it back up. Either we're going to make a decision with what we're doing right now. You're forcing us to, Lawrence, to move towards nursing homes, which is not what I want to do. I think I'm better, but that's selfish, right? Where I cannot, the current process doesn't, in my mind, address regression. And I'm talking about medical, where they're aging, because it doesn't allow us to come to step back to a setting where I can provide those supports in an environment where they're very comfortable, that they would choose. It's all the right things, it's just not set. And I think I know the pressure point, be respectful of the pressure points. But that pressure point is gonna cause people, I believe, especially with my shop in Lawrence, in our area, it's harder for me to give people chances now. And people that I would love to support longer, my team and I are having a look at and say, man, we may not be able to do this much longer. So I'm being a little bit of cry wolf here, I'm being a little ahead of it, whatever. But I see it coming, and I've already had a few, and I'm scared we'll have more.
Yeah, I think the residential needs process in many ways is broken because of the climate, right? So I hear what you see. I can tell you what I see. And what I see is providers with traditionally tier 4 beds going and screening people who are tier 2s and tier 3s and then asking for tier change requests, right? I see people that are really difficult that I can't get anybody to take. And so what's happening is part of it is the system is struggling right now to support the people that it needs to support. And so every time a request comes in to change somebody to a more restrictive level, you got a group of people who see 273 people sitting on a list that nobody will give a chance. So I think I agree with you. I think the things that got to get better, the things that are non-negotiable, the process has to be driven by the case manager. We can't get away from that. I mean, when we changed the service delivery system, that changed, and no matter what we say, that's going to be the process. And it's not because Lori Manus thinks it needs to be, it's because when we change that service, we don't have the ability to let it be a provider-driven system. So that's got to stay. So what we got to do is try to figure out how to build in something that benefits both sides of the system, right? Like one of the things we talked about, I think, Heather, you were in my focus group, right? One of the things we talked about was piloting kind of a presentation of the case manager to the group, because I think sometimes the case managers don't have the information that they need in order to be able to make a justification for somebody to change tiers. Because what they do is they send a request in that says, the residential provider said they need this. Not why, what's going on, what's happening with the person. So we got to get a little better with that. But I mean, you know, I hear you. I know it's bad. Every day, all day, I deal with all of these people who don't have anywhere to go. Like y'all were walking in today and I was making notes about who I need to talk to because I got somebody right now that needs to go somewhere. And, you know, I don't know the answer.
Lloyd, and I understand that the system has to be driven by case managers who probably have more on their plates than I can imagine. But when the residential provider, then their residential programs are being driven by an external party. If we could build some more systems in place to where it's a little bit more of a collaborative effort instead of, as a residential provider, sometimes we don't even know when someone's moving in to one of our programs or if they have Medicaid or an authorization. And if we could build in some systems where the residential provider could at least, without having to always run down overworked and overbusy case managers, see within the system move dates, authorizations, Medicaid. It is a challenge to run a residential program when an external party is essentially driving the process, just as it would be if case management departments were being driven by my residential program. So this is not a attack on case management. It's identifying weaknesses within the system that if we can improve that, then I think everyone benefits.
I agree. I think we have to find a way to bring in the residential provider when it's time to bring in the residential provider. I also think some of the other things that are broken is the way that y'all receive referrals. Like, sometimes case managers they're literally just blasting out a whole
They
bunch of
are. I
information.
got one today,
to
it
a
goes to the
whole-
director's email box, and I respond to those, but they are, you can tell me, they're just shooting
They're
them out.
and they're desperate. That's why they're doing
sure.
it, right? So,
Yeah.
we got to get to a point where, like, we're having a problem with case management, trying to get referrals out to case managers that they will pick up too. And, the whole system is experiencing an extreme access issue right now, which is really concerning, Go ahead.
I agree with you about the system experiencing this level of people not getting supported, especially at 243 you're talking about. But then when we,
73.
or 273. But when we agree to take 1, 2, or 3 of those, focus on that list, then I feel like still that we are at the end of not getting paid, because we may get an SLP1 assessment approved, but we may not get the authorization to 2 or 3 weeks later. But we've already wanted to start supporting this person because they're gonna be homeless or they are homeless. But then there's not much contact from, not all case managers, because we've got some great ones. And I don't wanna paint the picture that case managers are bad, because they're not. I work very well with most of them. But sometimes it is the process that holds it up. So if we get the SLP1 assessment approved, it's 2 to 3 weeks later before we get the authorization. We've missed, couldn't capture all of these units. And we've already had to pay for this person coming from a place that they don't have clothing, they don't have food, they don't have any startup.
Yeah, we're running into a lot more of that lately too, where people don't have any benefits, right? It's not just not about having money, they don't have their SSI set up yet, so we've had some situations where we've been trying to pay for, upfront costs, we've been trying to pay for rent. The issue with that is we can do that a little bit right now, but we better figure it out, because eventually that money's gonna dry up, and then what are we gonna do? So it's kind of like, one of the budget asks is some rental assistance. That's part of the reason it's one of the budget asks, because we keep seeing it more often. And like, people coming out of jails, these people come out of hospitals, they don't have anything, they don't, so what I'll tell you is, if you see trouble on my end, right, meaning the residential committee, let me know. I can get involved. One of the things we talked about with authorizations is when we approve and know a move date, we have the ability to just issue the authorization from our level. So we've started to do that a good bit. The problem is if we don't know the move date, we're not doing it, right? So we have to know what date that is. And then I want to pilot some stuff with some residential providers involved. But at the same time, we have to make sure that we're continuing to bring up case managers. I do think I have run into situations where the residential committee gets the level wrong, right? Like, I will look at something and go, like the person that I need something now for is listed at a certain level, and I think they could be supported at a more restrictive level. Some of that is because the residential needs committee is trying to pick least restrictive. But I think it's really hard for them. And I think when we get to the level of need assessment, a lot of this will work itself out, because it's going to be done by a third party. It's about what that person needs, what that person's level of service is, and hopefully we can get to a world where it's not tied to setting. Because the truth is, if somebody needs a certain level of service, they need that level of service whether they're in a CTH or an SLP or an ICF, which is kind of the whole concept behind level of need. When the tiers were built, they were built as a stopping place between the bands and where we really need to be. And the bands were around setting and level. So we're in kind of a weird spot right now
all I'll say is, if you want to talk about something, if you've got individual situations, y'all can call me. I'll do what I can. Jason knows if I don't agree, I'll tell you I don't agree, right? And I'll tell you why. If you get 6 months down the road and you say, okay, you were wrong and here's why, we can talk about it again, right? Like,
Very approachable.
I'm good.
You have, that's why I don't want to bombard you though. I just feel like, you you say call you, but then it's like all of us calling you. It's like,
Well,
you
but I don't
hate to do
think,
that.
it is a big problem. But honestly, it's not like you're having that problem with 25 people, right? Like you are not having that problem with 25 people. You run into a problem here and there. So it's a big problem when it's a problem, but it's not thousands of people, right? It's just kind of these individual situations that we have to figure out how to work out. That's all I can say. Everybody online is just sitting there.
Well, please let us know if there's anything that we can do for the collaboration, the conversation, to have that partnership between, you guys, CM, and residential providers. We'd love to have any way we can do to help you, because, we do have very valid concerns and issues, and I'm sure CM side of it does, because we do try to have that partnership. But I do think, like Tyler said, that collaboration, we would definitely be open to having that.
I did get IT to adjust the old ADT system, so that we could enter information into it and you guys could see it, but I have not implemented that. Number one, because it's an extra step of work. And number two, I don't want residential providers to get a false sense of security from the ADT system. But there is a way for me to enter into ADT that I approve that Johnny can go to Thrive at this level. Now,
There had to be.
you still don't have an authorization though. So if you look at ADT and say it's approved,
Yeah.
if you skip that step of getting an auth, you're not gonna be able to bill. So,
I'd rather just have the authorization. I mean, it's good to have the process, but I mean, if people get confused, because a lot of times we hear from the case managers, oh, well, they said it was approved that this person's at this level, but if I don't have authorization, it doesn't mean anything.
well, the authorizations tend to not be done until we know what the move date is going to be. So that's where it's tricky.
Transferring people or something like that, it
I know.
becomes trickier.
I know.
That'd be for the EHR, whether it's Thera or a different vendor, but could all that be baked into the system? Again, because I want to hopefully stay focused on systems improvement, not people. I like to manage systems because all of us, case managers, residential providers, everybody is just running ragged like crazy. So we can just bake in the solutions into the system, then it solves it for everyone.
Yeah, the RFP that went out included a robust admission discharge transfer tracking system.
Good.
That'd be good.
I feel like we have
And hopefully it had something,
discussion.
we've talked about, like, for residential, like you talked about earlier with the case managers and just shooting out these blast emails. If there was still some kind of database, a centralized location where residential providers, I mean, I don't care, we would have the responsibility to keep it updated, but that CMs can go.
I'm
and
trying to
look
get
at
to that. The
Uh-huh.
issue comes around security.
Uh-huh.
Like, I'm really struggling with, can I put information about people out there for any of y'all to go look at? And that, I'm getting a little bit of pushback, because what I wanted to do was just kind of a repository where you could go out there and say, what mails are out there? Who need us? Let me just pull their packet, and then no packets are flying around, But then there's problems with just a lot of people having access to a lot of protected health information.
That's what's happening now with the blast emails.
I know.
Yes,
Yeah, it is, actually.
So is
That's a good
there
point, 'cause
a
that's what-
way to, let's say you post something and I message you and say, hey, I want to look at this. You shoot me a code that's valid for a 24-hour time period.
Yeah, that's a good idea.
After that, after that 24-hour time
It
period.
expires.
It expires. That is a whole lot safer than you sending me all of this stuff electronically through the email. So there is a way that could be set up, surely, God, there's a way that.
Hopefully the system may allow, whatever system we go to will allow some kind of intake process that, I mean, I can only speak for there, because I, just from what I'm familiar with, they do have a system that you could, I could say, I want to look at this person, I'll look at them, deny them, you know, and it goes back to the thing that's protected, but something like you were saying, just as a repository would be good too.
Right.
And then that way the access is controlled and is time limited. Yeah.
She's right too. Therapy does have a referral module. The issue with it is an action has to be taken if a referral is made. So if a referral went out to 5 providers and you declined it and you accepted it and you declined it, but 2 providers did nothing, somebody's got to go find that and close it out, or it stays out as an open referral. Like, it's kind of this messy thing.
Open-ended.
Yeah.
Huh.
Because we actually were going to use it. I don't know if you remember that. We kind of put something out and told you we were going to, and then when we realized kind of this openness that was going to be out there related to these referrals, we kind of backed off of it a little bit. So, but I'm aware the residential needs process. We are planning some training coming up. I encourage you to sit in on it. And for everything that it's not, in its last year of inception, it has grown. Like, people are doing leaps and bounds better than they were in the beginning. So that's good. You know, it means that the system is moving in the right direction.
Would it be possible for the residential provider to own the move-in date and the case manager to own the authorization?
Yeah, I think that would be okay as long as a residential provider understands. The trick is the residential provider has to understand that just because DDSN said that you can move Johnny in on the 2nd, if you didn't get that authorization, you not gonna be able to bill.
Yeah.
Not me, not, right? So that's where it gets super tricky. Because what used to happen in the old world is providers moved in people whenever they wanted. Sometimes case managers didn't even know about it for 3 weeks. We didn't bill it to Medicaid, but we still paid you, right? So that's kind of what used to happen. And so we've had to kind of switch it all around to make sure that y'all get to the point. People, I think, finally understand the need for authorizations. I think y'all have gotten that loud and clear. But it took a while. It took a minute, so.
Where are we with the cases for the conflict-free case? I'm just curious, because I know we're coming, we're coming.
Yeah, I looked at it last week. We only anticipate that there might be an issue related to head and spinal cord injury cases. And there's less than 15 of them. So we've told HHS, and I'm waiting on what to do about it. We put out a solicitation for some intensive case managers, some people to manage some of these really high profile people. Based on the solicitations that we got and the funding for it, we've made the decision to hire them centrally. So you'll see a posting go out soon for some intensive case managers at the DDSN level who will likely be assigned cases that are court cases, right? Like any of the folks that are in the process of being judicially admitted until they get where they're going. And then these cases of people that are in hospitals and jails. Because we're just not getting movement. We're kind of doing it anyway. So.
How many people are you hiring?
7.
It was existing positions, so it's not a problem. It's just not something that I really wanted to do. But we have to find a way to start making some movement on these. But I do think we'll learn something with that as well. That these state level case managers that we have now, we've already learned that a standardized packet works better than just sending out a whole bunch of stuff with a whole bunch of information in it. We're trying to get really good at using the face sheet, information sheet on the people. That might be something that we can post without a whole lot of information. So you at least know more about them than initials in some little, this is the area of the state they live in. So hopefully we'll be able to take some of the stuff that we learn in this world and move it out. I have probably at any given moment 70 or 80 case management cases that I can't find a home for. I've even, like I said, there's a problem with accessing residential. There's a problem with accessing case management, you know, because like Lawrence, for example, let's say that Lawrence has 2 full caseloads, right, of case management. And all of a sudden, something's going on with somebody who is extremely involved, sitting in a hospital. I'm asking them for weekly updates on that person. They don't have the bandwidth to take on a case that requires weekly updates. So that's kind of what's happening.
Well, I think I shared with you, we just did a new residential admission for a young lady that had been in the hospital in the upstate since April. And as a provider, you can imagine you're a little weary about that, but she's came to the CRCF, and so far she is doing awesome. So we're really excited about that.
Well, a lot of times these folks in the hospitals, we don't really know what's going on with them, right?
Yeah.
So, you know, we opened Walnut, right, for kind of respite. And I think you guys heard, those of you who've been at the DSN board meet and greets anyway, I know it was discussed there. We're looking at doing the same thing for adults at Witten, kind of a male and a female unit. But the concerning part with Walnut is it's now full.
Yeah. And you said it for 8?
And I don't have anywhere, and we're trying to move them out. That's one of the things that this group's gonna do too. So they're gonna be responsible for the 8 people at Walnut and trying to sell them.
Those 7 case managers,
Yeah.
is that what you're talking
One
about?
of them will be
focused on
assigned
that. Yeah.
Walnut.
Because, I mean, as far as the RFPs.
And the other 2.
RFPs from the residential providers on that, I mean, I hate to say it, but I mean, that's what it was referred to, the new eject, reject. Did y'all get any?
Yeah, we got some.
Okay.
So those are in the works.
Well, that's good.
I think another challenge is like tier 3 and tier 4, maybe typically they're not probably gonna be able to go to like any kind of day program. Sometimes they might.
3 should be able to.
They'll take, and folks will take them. Accept them. They may not. I'm saying this is a challenge. It can be very problematic. Sometimes yes, but sometimes no. And so the rate is, you're thinking they're gonna be gone during the day, but really it turns into a 24-hour rate. So it already becomes insufficient before you even.
You know, the issue, it was built as a 24-hour rate. That's the problem with that argument. Like, when you try to talk that through, when they developed those rates, they developed them with a 24-hour staffing pattern.
Who did?
HHS.
I don't see that.
They did though. I mean, I'm telling you, because.
That's wrong, because you have to have a day unit to make it work. You have to have 2 day units to make it work.
So I think y'all, didn't they share with you the initial like workup and how they came up with this many staff around the clock?
We look at it again, but if that's the case, then we all missed it, because it doesn't come close to supporting that.
So I will tell you that when those rates were built, they were built as independent rates.
Yes, but that's not 24 hours
They were built.
necessarily. It could be, but it'd have to be if they were built as independent rates.
They did not make any assumptions that people would be gone during the day.
How they
When those
justify
rates were
day,
built.
then how they get the day rate.
Separate rate, yeah, exactly.
The day rate's a separate service.
I
So,
agree, but
so what they're saying is, you know, if the tier 2 rate says that you have one person on first, one person on second, one person on third, right? Which it says a little bit more than that, but let's just say it does. If one person doesn't go to the day program, you still have one person on first, so you're good, right? So that's kind of how they don't assume that a whole house of people will leave every day.
But when they were baking in their staffing patterns into those assumptions. So,
Maybe that's where it's built in.
right, because if you're assuming that, because they're not assuming 1 to 4 or 1 to 1 during the day. So if 3 individuals go to the day program and you got someone at home. you have
Their
to staff
staffing
it.
patterns are based on number of hours per week. And the number of hours per week include staff on every shift, all of the rates. I mean, I'm just telling you what I've seen and how they were built, because I wasn't here when they were built either. But that is the way those rates were constructed.
Yeah, I mean, because you can't assume, I mean, I know the old way of doing things with the board
Right.
providers, and they had the day program and residential
Right.
pros, and everybody rode the van to the day program. It's not that way for qualified providers, especially some of the ones, because, you know, we're relying on, you know, Heather to let us bring somebody into her day program, and she's like, she threw a chair across the line.
I think about it.
She says she'll think about it.
But yeah, so I mean, we have to start out with the notion that this person is going to be here 24 hours a day, and we're going to have to staff that person 24 hours a day.
Right.
This is a challenge, that's, you know,
Yeah.
that's what I'm just saying, that's just a challenge.
And as, I mean, I think out of 20 houses, I only have 2 houses where everybody is going during the day.
Yeah, because the ban was to both rates combined, so it was both res and day, because you're gonna have them 24 hours, but then I don't see how that could have been factored in.
Yeah, well, the rates don't really mirror the bands. The rates are based on the idea of the rates are based on the bands, but they don't really mirror what the band payment was.
Yeah, but when he gave us a breakdown, Jeff, and he was saying, okay, this number of units you build, you know, whether it's day or employment, or res, and this is how it factors in when you're looking at the rates. It was, I know we were less because we didn't have day. And he made that comment. He said the folks that have both are gonna make out a lot more because they have both.
Yeah. I think too, you know, the good news is, I don't think that these tiers, I think everybody kind of knows that we need to relook at the tiers, right? Again, they were a stopgap. Somebody developed them to get us through. So I think the more knowledge that you can provide related to how these tiers work or don't is the better off you'll be, you know, and you got to stay away from, I know room and board is a huge issue. You know, I mean, housing is terrible right now. But that's not part of the service. So just make sure you don't wrap any of that into it. All right, well, y'all have beat me up enough today.
Lori, it is appreciated though.
We appreciate you. We appreciate you. We
Being able to
do.
come in person and ask questions face to face is helpful.
Yeah.
I'm sorry everybody left you, because we said last month we were gonna do this today, so I'm sorry for you. Everybody built it on.
You know, a lot of people take this week off, and I'm kind of that whole opposite, like when everybody's off, that's when I want to be here. And then, like, I want to be off when all y'all are here and I'm not, you know. So I tend to always get the holiday short end of the stick. But I think, you know, whatever, it'll be fine. I don't mind ever meeting with y'all. Thanks for everybody online.
Appreciate it.